afternoon again, and thanks to all of you for joining us today. I'm Beth Stroll with the TA Network for Children's Behavioral Health, and I'd like to welcome you to this month's System of Care Leadership Learning Community meeting. Denise Silsbeck and I co-facilitate this learning community. We hold it monthly, and it's designed to support leaders in systems of care in states, communities, tribes, and territories, those with and without federal grants. We try to adjust topics that are important to you, and we always welcome your suggestions for future topics. This year, we're going to focus some of our sessions on operationalizing various elements of the system of care approach, which was a need expressed by many of you, and today's session will focus on financing. We do like these sessions to be as interactive as possible, so we encourage you to put your questions and your comments or insights in the chat box throughout the session. We have incorporated time for questions and answers and dialogue, and Denise and I will make sure that any questions you enter in the chat box are addressed. Just below the chat box, you'll see a box that will allow you to download today's PowerPoint presentation and a number of other resources. And as a follow-up, you'll receive an email with a link to the recording of the webinar that you can refer to and share with colleagues. Also, at the end of the session, a link will pop up for a very brief evaluation survey, and we would really appreciate you taking just a few moments before logging out to complete that and provide us with feedback. We do take it seriously, and we try to use it to improve future learning community sessions, so we would love for you to take a moment to respond to that survey. I'd also like to tell you about a new learning platform that the TA Network will be adopting that will allow you to easily access all of the materials, presentations, recordings, and such on particular topics, and will also offer some vehicles for you to interact with your peers and share resources. More information about this and how it can enhance the learning community experience will be available soon. We ourselves are in the process of learning about it and its capabilities. Before we get started, I'd also like to mention that our next learning community meeting is December 12th, also at 2:30. The focus of that one will be on operationalizing social marketing, strategic communication, and National Children's Mental Health Awareness Day. There will be information on available technical assistance on social marketing, and then the topic and plans for National Awareness Day in May 2019 will be revealed, I think actually for the first time publicly. And then presenters will also provide some examples about how states and communities have leveraged Awareness Day to achieve their goals for children's behavioral health and systems of care. So we hope you'll put this on your calendar and that you will join us then. Again, today's session will focus on financing, and will provide information on some new developments and opportunities for financing children's behavioral health services and systems of care. The objectives are to look at changes in the financing landscape, to highlight some new opportunities within Medicaid and child welfare, and to discuss ideas for leveraging these strategies in your own states and communities. And we are very fortunate to have Sheila Pyries as our presenter today. Sheila is the managing partner of Human Service Collaborative and is a core partner of the TA Network, where she leads our policy and finance hub. She's an expert in many aspects of building systems of care and is well known for her expertise in all things financing related to children's behavioral health. You may know her already, as she's worked with many states and communities. And now I will turn this over to Sheila, who will get us started.
Okay, thanks, Beth. And I'll just advance my own slides, if that's okay. Hello to everyone, and I'm going to be talking about actually some new financing opportunities and changes that are upcoming. The Integrated Care for Kids model through the Center for Medicare and Medicaid Innovation, the Family First Prevention Services Act, which makes major changes to Title IV-E financing in child welfare, and a new opportunity from the U.S. Treasury Department on social impact bond financing. So I'll start with the InCK model, Integrated Care for Kids. This is the Center for Medicare and Medicaid Innovation's first pediatric model, which we were happy to see. Some of you, I know that we at the National Technical Assistance Network submitted comments, and some of you may have, when CMMI issued a request for information earlier. And we put the link to this, to CMMI and the InCK model in the last slide, and it's worth going on there both to get more information, but also they posted all the comments that came in. And a lot of them had to do with children's behavioral health, which we were, obviously ours did, but there were a lot others, and we were very pleased to see that. And as a result, this first pediatric model has a clear focus on behavioral health conditions and risk factors such as trauma, involvement in foster care, substance use. And its purpose is to test innovative payment and service delivery approaches to both reduce costs and improve quality through prevention, early identification, and treatment of behavioral and physical health care needs. So there is a focus on integrated care, but a recognition of the broader so-called social determinants of health that affect health and emotional well-being. And these grants, these grants will require a partnership between the state Medicaid agency and a local lead entity, which I'll talk about in more detail in a second. So these InCK goals are right out of the description of the model, and you will see the resonance with system of care goals, reducing fragmentation and improving coordination. Again, you see across medical, behavioral, and social service systems, the shift to home and community-based services and reduction of out-of-home placements, which InCK defines very broadly as inpatient residential treatment, foster care, detention. And that is innovative in the sense that this is a Medicaid opportunity and an opportunity really to sort of integrate, I think, system of care kinds of technologies and principles into an InCK model. So the fact that these, such as out-of-home placements, are broadly defined, I think is really interesting and provides a lot of opportunity. They have language in there about putting youth and families first. That's not terribly well defined, but again, they haven't issued the full notice of funding opportunity yet, which will be forthcoming sometime in the next few months. They said fall of 2018, which I think we're almost out of, and some of you are probably experiencing full winter. And improve and align measures of child health and behavioral health across child-serving systems. And importantly, implement alternative payment models that are aligned with quality measures. That last bit about these InCK models have to adopt alternative payment models, which some of you may think of as value-based purchasing arrangements. And I put this slide in here just in case some of you weren't familiar with it. It's a very nice framework for thinking about alternative payment arrangements that the Healthcare Payment Learning and Action Network put together. And it walks you across from category 1, where it's strictly fee-for-service and not linked to particular performance measures, in this red box, which are kind of less sophisticated, if you will, alternative payment arrangements. So for example, an alternative payment arrangement could be just paying providers or managed care companies for reporting. But typically it is rewards or penalties for performance. Moving across to the green box, where you'll see things like population-based case rates. And all of these are used in our various system of care arenas. So even at the most sophisticated end, you think of a wraparound Milwaukee, which is using both capitation and population-based case rates that are tied to performance measures and has been for some time. So I think we have very much have things to contribute in that arena. The InCK design, the model, has to address the following core services and how they will be coordinated. So clinical, both physical and behavioral health, the interface with the schools, with housing, food and nutrition, early care and education, the interface with Title V, maternal and child health, child welfare, and mobile crisis response is specifically mentioned as well. There has to be one point of contact for families and a comprehensive needs assessment that's culturally and linguistically competent. I'm going to crosswalk some of these in a moment with things that are going on in the system of care world that can inform InCK models. Other design characteristics, there has to be a population-wide approach. So you have to focus in a particular geographic area on the entire Medicaid population. You may also include the state children's health insurance population, the CHIP population as well. It has to be person and family-centered service delivery. You see again these sort of values that come out of system of care embedded into this InCK approach, and which you hear also more often in health reform in general these days, which I find a little ironic since they've been concepts in systems of care for over 25 years. Service accessibility, again, you see mobile crisis response, information sharing, and the alternative payment models. So returning to this concept of the whole population focus, this again is right out of the InCK model. So there have to be population level goals. So you have to focus on all children, which is that level 1. So if we think of, if you think of prevalence for mental health conditions, for example, among children, if you had a total Medicaid population, about 80% of children will not have a need for specialized behavioral health care, but about 20% will, and that 20% is going to fall into the level 2, level 3. But you're focusing on the entire population in Medicaid and providing, so for example, in level 1, your goals may be things like improving access in general. In level 2, you may be implementing things like team-based models that integrate primary and behavioral health care. And in level 3, you may be looking at, because you're focusing on children with the most complex conditions, at things like a intensive care coordination with a fidelity wraparound approach. So this partnership between the state Medicaid agency and a lead local organization is a requirement. And either entity can be the awardee, can receive the grant, but the application has to be a partnership, and it can't just be a letter of support. The state Medicaid agency, for example, has to commit to providing data around the population, to working with the lead entity on developing an alternative payment approach that's sustainable, on looking at whether existing waivers used in the state are viable or whether the state will have to pursue some additional waiver or options. The lead local organization, again, more will be coming out on this in the notice of funding opportunity, but so far what CMMI has said is that it must be a local HIPAA-covered entity that's accountable for population health outcomes. So that could be a local health or behavioral health department. It could be a managed care organization. It could be a hospital or a healthcare delivery system or pediatric and behavioral health practice. Applicants have to identify a geographic service area, and it cannot be statewide. So the InCK model is focusing on an area, because there has to be a state comparison group that's similar in size and demographics. Somebody asked me recently whether the comparison group could be out of state, and we didn't know at the time, but CMMI has clarified that, and it has to be an in-state comparison group that's similar in size and demographics. The population could also include expectant mothers. So for those of you that may be working on, for example, pregnant and postpartum women with substance use issues and their children, that population could be included along with children in general. The awards will be up to $16 million over a 7-year period. with years 1 and 2 being pre-implementation and years 3 and 7 implementation. There will be up to 8 awards. They hope to make them in the summer of 2019. The funding can be used for planning, for feasibility testing, for implementation supports like training, and for evaluation, but they cannot be used for direct services that would duplicate Medicaid or CHIP reimbursement. And again, we'll expect more clarification when the NOFA comes out. The Center for Medicare and Medicaid Innovation will provide technical assistance, peer-to-peer learning. Okay, so let me just crosswalk quickly. There's been a kind of foundation for what could go into an InCK model through previous relevant federal guidance and initiatives. So when we think of the May 2013 Joint Informational Bulletin that the Centers for Medicare and Medicaid Services and the Substance Abuse and Mental Health Services Administration issued on behavioral services for children, the January 2015 Joint Bulletin on behavioral services for youth with substance use disorders, obviously the System of Care Grant Program. Some of your states were involved in the Psychiatric Residential Treatment Facility, or PRTF, Demonstration Waiver Program, and a few of you were also involved in the CHIPRA Care Management Entity Quality Collaborative. So let's sort of look at the relevance here. I just want to reiterate this point, that many states and localities are implementing child behavioral health best practices that align with InCK goals, but innovations may not yet have been integrated within Medicaid delivery systems. And that's the opportunity that InCK provides. Many of you are focused on integrating system of care reforms into Medicaid, and this might help to jumpstart some of that or advance it. So let's look at their goals and what's going on in the system of care world that's relevant. So reduction of out-of-home placements and increasing home and community-based services. Some of you have probably participated in the mobile response and stabilization services peer-to-peer meetings that the TA network has held over the last few years. We're seeing very good results with these newer generation models that are implemented in states like Connecticut and New Jersey and in some of the counties in Wisconsin and Washington State. And some of these, data are here for you. New Jersey, for example, which, over 90% of children that are served by their mobile response services remain in their current living situations. That's very good compared to normal crisis diversion rates of more traditional crisis systems. Same thing with Connecticut, which is experiencing cost savings to Medicaid in inpatient and emergency room diversions. Intensive in-home services. Many states have redirected resources from long lengths of stay or placements in residential care to expanded home and community-based services. Intensive care coordination using Fidelity wraparound. Care coordination will have to be a key ingredient of an InCK model. And I don't know of any other approach besides intensive care coordination with Fidelity wraparound, and Fidelity being the operative word here, that has the data showing its effectiveness besides this. There are some interesting data around other coordination models like collaborative care management for adolescents with depression, but it's primarily adolescents using office-based services. It's not the populations of children and youth that tend to use wraparound. Family and youth peer support. Some 30 states now cover family and youth peer support in Medicaid, which really came out of the system of care movement in terms of families and youth with lived experience in mental health systems. Respite care, a key ingredient, and many states have waivers that would allow provision of respite or are already providing respite. Substance use, like New Jersey's treatment continuum for substance use and its use of substance use navigators. The InCK goal of ensuring a comprehensive needs assessment that's culturally and linguistically competent. Many states in their systems of care use standardized, culturally and linguistically competent and strength-based screening and assessment tools statewide, like Child and Adolescent Needs and Strengths, the CANS, the Child and Adolescent Functional Assessment Scale, and the Child and Adolescent Service Intensity Instrument, or CASI, and just, some examples of states, which, there are many more. So again, something to bring to the table. So InCK has a goal of primary health and behavioral health integration, and the Technical Assistance Network last year pulled together an expert convening of primary care practitioners who've paid a lot of attention to this concept of integrated care, as well as behavioral health stakeholders, families and youth, and others, including some of the federal key stakeholders, to see if they could achieve consensus on what an integration continuum for children who have behavioral health or are at risk for would look like. And it took a population focus, so for example, all children in Medicaid. And what they agreed on is, this group agreed on, is reflected in this graphic, where you'd have an integration continuum that is nested within common values and principles. Those principles look very much like system of care principles, like InCK principles. And across the continuum, they felt that family and youth peer support and family and youth system navigation is recommended across the continuum, so for all children and families. And that there should be metrics, measures across the continuum that were child-specific. And that for children who are identified with behavioral health challenges, and particularly those with significant behavioral health challenges, those measures needed to extend beyond the national quality measures, like the HEDIS measures, that you see in many, for example, managed care contracts, which are fine, they just don't go far enough when it comes to children with significant needs. So for all children, in this first box here, they recommended promotion of social and emotional development, developmental and behavioral health screening, and family psychosocial screening with a broader focus on social determinants of health. This group did not want to get sort of mired in where should that happen, and they felt that any of these things could occur in primary care, behavioral health, school-based, or other community types of settings. The reality is that most screening for Medicaid enrolled children happens through the early periodic screening and diagnosis and treatment program, and is done through primary care providers. Then for children with identified needs, they recommended in the second box a child behavioral health, that there be child behavioral health consultation programs, which include behavioral health consultation to primary care practitioners and coordination, and again could occur in any setting, and then also early childhood consultation programs like the Head Start preschool programs. For children who have low to moderate behavioral health needs, this group recommended that there be team-based care within an appropriate supportive infrastructure. So training around how to do team-based care, information technology systems that support team-based care. And again, that could happen in any setting. And then for children with significant needs, multi-system involved, etc., the group recommended intensive care coordination using Fidelity Wraparound. So that I'm putting this here because it provides a kind of framework for thinking about an InCK model that's focused on a total population of Medicaid enrolled children. All right, alternative payment approaches. I mentioned Wraparound Milwaukee already, which has had very good results in its use of not only pooling funding but using capitation and case rates. Oklahoma providers can earn a bonus for individual measures that a lot of which are tied to access, to increasing access, and they've indeed seen an increase in access. And multiple states, including some of yours, use bundled care coordination to pay for intensive care coordination and wraparound, where the provider is also, those rates are tied to quality and outcome measures. And then, a number of states are implementing accountable care organizations, usually focusing on all populations, not just children. Massachusetts is in the process of launching a youth-specific accountable care organization, which we're looking at with interest. This was just a slide. I had done something on InCK for the Family-Run Executive Director Leadership Association, FREDLA, about the roles that families and youth and family and youth-run organizations could play in terms of InCK development. And what's on this slide is also true for any other system of care stakeholders. So encouraging state Medicaid agencies to partner with local lead entities on proposals that have a primary focus on children with behavioral health challenges, because there's a possibility that a lot of the proposals that come forward will be focused more broadly on children with special health care needs, and will come from hospital-based and healthcare delivery systems, primarily physically health-oriented. And I think that is not that, that's also a population that can benefit, obviously, but it's a little bit different population from the populations of children and youth who have behavioral challenges involved in systems of care. And so we're hoping that there will be a lot of proposals focused on sort of our populations of children and goals around that. So encouraging local lead agencies to talk with Medicaid, being involved in proposal development around incorporating the right best practices, including involvement of families and youth as partners, and making sure that the outcomes and benchmarks are relevant. And so I just put that in there as well, because it's really applicable to all stakeholders. So the key takeaways for InCK are that it presents an opportunity to expand system of care best practices, and particularly these ones that I've bolded here, and can help us to further address common concerns like high out-of-placement rates, insufficient access to home and community-based services, and payment models that are disconnected from quality. Okay, I think we pause here for a moment to see if there are questions regarding InCK before we turn to the next topic. And I think you all have to type a question. Is that right, Beth?
Yes, that's correct. We have a large group, so it would be difficult to open the lines. If you have a question, please put it in the chat box. Sheila, you can continue, and if questions are, maybe one is coming up now, but if we get questions, we will save them and refer them to you as you move on.
Okay. Okay, I'll go ahead then and move on to, no, I won't.
Oh, here's one, Sheila, before you do. How do you address the needs of co-diagnosed children with mental health and developmental disabilities, like children with autism and mental health issues?
Yeah, I think that you would want to address that population of children with co-occurring issues, just like you would with children and youth with co-occurring substance use, not in the same way, but you want to address those issues as well. I'd really encourage you to take a look at what New Jersey is doing through its system of care for not only children with co-occurring intellectual and developmental disabilities, but all children with IDD, not just co-occurring, and taking a system of care approach with that population, and that's what I would suggest. Okay. So let me switch to Family First. Okay. And Beth, you can just interrupt me if I see people typing, but it takes time to type. So, just interrupt me. I'll go back to InCK. Okay.
Sure, or we'll save some of your questions for the end as well.
All right, let me just answer this one because it's quick. Joe Rosano asked whether the funding that's coming in 2019 is one-time or for a period of years. So it is over 6 years, is it? Did I say? The first 2 years are for planning, and the succeeding years are for implementation. Now, whether it will continue beyond that time period, who knows? Okay. So, Family First. This legislation now act allows use of Title IV-E for prevention services and supports, and by prevention, the act means services and supports to prevent placement of children into foster care. And it's effective in October of 2019. It's a state option, so states don't have to opt in, but it allows for as you know, or maybe don't know, Title IV-E historically could only be used for children who were in and out of home placement. And so it created this sort of perverse incentive to remove children, because then you could tap into Title IV-E, which is a federal and state match program, sort of like Medicaid. It's an entitlement program, and the feds contribute half the cost. And so there was this kind of weird incentive. And Title IV-E monies are much, much bigger in size than family preservation dollars from in child welfare. So for the first time, except for those of you who may have had Title IV-E waiver programs that allowed something like this as well, you can use those IV-E dollars now for services and supports to prevent placement. Those services and supports can be provided up to 12 months. And there's some wiggle room if a state makes a case that the services are needed beyond 12 months. But in general, 12 months. And the specific services mentioned include services, and this again is language out of the Act, services to address mental health challenges, substance abuse treatment, and in-home parent skill-based programs, including parent education, individual and family counseling. And also, the Act allows reimbursement for Kinship Navigator programs. The services and supports have to be a promising practice, a supported practice, or a well-supported practice, and trauma-informed. The Children's Bureau, Federal Children's Bureau, has awarded a contract to Apt Associates in Massachusetts to develop and manage a Family First clearinghouse of these practices. And the National Technical Assistance Network, among others, is having conversations with the Children's Bureau and eventually with Apt Associates about many of the things that I just covered in InCK, making sure that they're included in the clearinghouse. The state has to have a prevention plan approved by HHS and that describes the services and programs that will be implemented. The funds can also be used for training and administration, including data collection and reporting. The eligible populations to receive services include parents or relatives who are caring for children who are, quote, candidates for foster care. That is, they're at imminent risk of entering foster care, but could remain safely at home with the right services and supports. Also, adoptive parents and relative guardians where placement disruption is an issue. And as you know, placement disruption often is related to the child's behavioral health challenges and the parents or guardians not having the resources and supports to be able to manage the child at home. And then also eligible are youth in foster care who are pregnant or already parents. And these populations are eligible for services regardless of whether they meet the Aid to Families with Dependent Children, the AFDC income eligibility requirements for 4E reimbursement, which is a very big change because it opens up these services to a much larger group. The Act also extends to age 23 supports for youth who are transitioning out of foster care, and it extends to age 26 eligibility for education and training vouchers. In addition, 4E dollars can be used for up to 12 months for a child who's placed with a parent in a licensed residential family-based treatment facility for substance use. So if you are developing residential programs for pregnant postpartum women who are involved with substance use, that's another population. Also, 4E reimbursement, as I mentioned, are allowed for Kinship Navigator programs that meet these promising or supported practice requirements. And again, that's regardless of whether the child meets AFDC income eligibility criteria. Performance measures and data collection and reporting are required, including the services provided, the expense associated with the use and the duration, and the placement status of the child, and whether the child enters foster care within 2 years. The sort of second half of Family First, and these are connected, very much so connected, is that it places limits on the use of congregate and group care. The states can seek a 2-year delay on that, so up to 2021. Residential treatment programs have to meet new Qualified Residential Treatment Program, or QRTP, requirements that include the following, and then again, this is language from the Act. The program has to have a trauma-informed treatment model, have registered or licensed nursing staff and other licensed clinical staff who are available 24/7 and available to provide services on site. They don't have to be employees of the facility itself, however. I know some of you that have smaller residential programs are concerned about meeting this requirement and having to turn those programs into sort of a more medical model. We're all still awaiting guidance from the Children's Bureau, and you know, we'll see how they address that, but I know a number of states have raised that question. The QRTP, the residential program, has to facilitate family participation and family outreach and document how they're going to maintain contact information for families and kin, how the family is integrated into the child's treatment, including post-discharge, and how sibling connections are maintained, provide discharge planning and family-based aftercare support for at least 6 months post-discharge, and must be licensed and nationally accredited. You'll see and hear some of the Building Bridges Initiative principles, for example, providing family-based aftercare support. And I know some of your states are looking at payment models that would allow residential programs to provide that kind of aftercare support in return for meeting certain outcomes, like not returning to another institutional placement within a period of time. The Act also requires that there be assessments done of children who are in out-of-home placements to determine the appropriateness of the placement, and there are time frames set. those assessments have to be done by a trained professional or licensed clinician who is not a state employee or an employee of the residential program, although that can be waived if the state can demonstrate objectivity. But that's clearly a role in here for, partnering with the behavioral health system. They have to use evidence-based functional assessment tools, and again, Children's Bureau is supposed to be releasing guidance on valid tools. I can't imagine that a number of the tools that I just mentioned, like the CANs and the CAPs, would not be included, since so many states are using them already. And the assessment has to be done in conjunction with the child's family and permanency team. Now, what's interesting here, and again, I'm giving you sort of my speculation and, kind of others from the TA network where we've talked about this, because guidance has not come out from the Children's Bureau yet, but it's unlikely that this act will apply to psych residential treatment programs, PRTS, because they don't use 4E funding. They're 100% Medicaid funded. Similarly, the act is unlikely to apply to residential programs that are funded with 100% state or local general revenue dollars that aren't using 4E. So that could create opportunities for cost shifting to Medicaid and other systems. Although there is a requirement that the state certifies that Family First changes will not increase the number of youth entering juvenile justice. Family First is really a positive thing. It's a very positive thing in many ways, but there are always these kind of unintended consequences if a state is not thinking through a system of care lens, in effect. Because when you think about it, the requirements for qualified residential treatment programs in Family First, they're the same kinds of qualifications you'd want any residential facility to have. And the goal of trying to reduce lengths of stay, for example, are similar goals. They're very much connected with building bridges kinds of goals. So it would make more sense, it seems to me, for states to apply the same criteria from a quality standpoint. Things like family engagement, like aftercare support to families, like youth partnership, like having a trauma-informed approach to all of their residential facilities, regardless of whether technically they're going to fall under Family First or not. So the Children's Bureau, as I mentioned, is issuing program instructions and information memoranda rather than doing a lengthy regulatory process. What they're planning to do is laid out in an October 1st, 2018 letter, and I think we have the link to that at the end, from Acting Commissioner Jerry Milner. The letter talks about what they've already done, including convening teams from all the states. And I don't think they're completely done with that, though. They've released 2 information memoranda, and they requested that states provide by November 9th the certification of their intent to request a delay of the congregate care requirements, which, as I mentioned, you could request a delay for up to 2 years. And they aren't holding the states to that. They're really trying to get that information to help them with their budget, figuring out their budget for technical assistance. So those certifications aren't binding. The states still have until September 29th to make the final decision, because Family First goes into effect October 1, 2019. I suspect that this administration will give the states a fair amount of flexibility and will provide more guidance than kind of hardbound rules around Family First. But again, we have to wait and see what Children's Bureau comes out with. So the bottom line here is that Family First does present an opportunity for child welfare, behavioral health, and Medicaid in particular to come together and look at how it could be used to expand mental health and substance use services for children who are a very high-risk population at risk for child welfare involvement or for placement disruption. It's an opportunity to expand supports to families and caregivers, expand family-driven and youth-guided practices, get better data on mental health and substance use service provision to this population, and improve the quality of residential care. And again, Family First can address these common concerns that all of the systems share, like out-of-home placement rates that are too high, placement disruption rates that are high, insufficient access to home and community-based services, and poor performance on quality measures. Okay, I should stop there and see what questions there may be. I'll give it just a moment. Okay. All right, let me talk about this this last opportunity. The Social Impact Partnerships to Pay for Results Act, or Supra, also sometimes just known as the Results Act, and it created a $100 million fund at Treasury to support state and local pay for success initiatives. And half of those dollars have to be for projects that directly benefit children. Among the priority outcome areas, and again this is from the Act, are improving the health and well-being of those with mental, emotional, and behavioral health needs, reducing use of residential and other congregate care, reducing the number of youth in foster care, reducing recidivism among youth in juvenile justice, and increasing employment and earnings among 16 to 25-year-olds. These initiatives have to achieve one or more measurable outcomes defined by the state or local government that results in positive social outcomes, as well as savings not only to the state and locality but to the federal government. So pay for success or social impact partnerships or social impact bonds are public-private partnerships in which private investors, foundations, businesses provide upfront capital in order to scale up proven practices that can achieve measurable outcomes. And then government funders, because the savings are accruing, if the return on investment in effect is accruing to either the state or local government, repay the investors only if the outcomes are achieved. And then typically it's provider organizations that are implementing the best practices that can create that return on investment. So one example, for example, is in Connecticut, the Family Stability Pay for Success Project, which was undertaken by the Department of Children and Families, which includes their child welfare and children's mental health and juvenile justice components. The goal was to improve family stability and reduce parental substance use for DCF-involved families. And the project leveraged $11 million in private sector capital in order to scale up family-based recovery, which is an evidence-informed practice developed by Yale Child Study Center. The government repays investors if out-of-home placements are prevented, if re-referrals to DCF are prevented, if there is a reduction in substance use by enrolled family members, and if there overall are successful enrollments in family-based recovery in the program. So Supra funding will support, most of it will support, up to $75 million, will support outcomes funding, so helping to to reimburse investors for upfront monies if outcomes are achieved, funding for evaluation of the project, and funding for feasibility studies. The notice of funding opportunity or availability is expected in February, I think, 2019. And, we're looking for, obviously, more information about that at that time. It's an opportunity for state and local agencies to implement effective approaches on a broader scale where outcomes can be achieved and there's a return on investment. So, for example, some of you are piloting intensive care coordination using Fidelity Wraparound. And we know from other national demonstrations and other places like the PRTF waiver demonstration and other places that have been implementing Fidelity Wraparound for quite a while, that there is a return on investment. So this could be a way of scaling that up. Same thing with mobile response, where that newer generation model does yield a return on investment, a savings in terms of inpatient and residential use and emergency room use. Peer support, which is often a companion support to some of these other interventions like wraparound and mobile response. Psychiatric consultation to primary care. There could be savings achieved, for example, in psychotropic medication use. And then supported employment for older youth and emerging adults. And again, CIPRA, like these other initiatives, can help to address common concerns, like out-of-home placement rates, overuse of psych inpatient in ERs, overuse of psychotropic meds, and lack of employment options for older youth and emerging adults with behavioral health challenges. So I think it would, make sense to see if there are any questions or comments on any of these three opportunities that are emerging, and then to see if there are planning activities underway in your own states around any of them that you'd like to share. I know we'd be really interested in knowing, what you may be doing already. Like, are you already working with child welfare and Medicaid on Family First, for example?
Sheila, there's a question from Joy. Who does the CIPRA money actually go to? A particular state department?
That's a really good question, and I think until the NOFA comes out, we don't really know the answer. I would speculate that it would go to, I don't even want to speculate, because it could be organized in any number of ways, really. The state could be a partner, but the dollars could actually go to a provider entity. So until it comes out, I don't really know.
Okay, and question from Kristen. I'm a local assistant care coordinator in Indiana. We implemented high fidelity wraparound, and many of the suggestions are on a more state government level. How can any of these strategies be approached by a local system of care?
Well, I certainly think the social impact bond funding could be a local initiative. It wouldn't have to be state. And again, we'll see what the NOFA says, but certainly there have been, places around the country where a locality has generated this kind of upfront capital and done a kind of social impact bond initiative. New York City did one, for example, around youth in detention. Family First Act, is affecting, the lead on it has to be the state 4E agency, Title 4E agency, which is the child welfare agency in the state. But it seems to me that you'd have a more effective approach if you worked with your localities on what will work in those particular localities. So an effective service or support that might be particularly useful, in your locality that you've already tested that may not be on the state screen. So I think, there's definitely a role for local systems to try to inform these discussions and then be involved in implementation in terms of providing services, once there's a plan in place and after October. Integrated care for kids is there can be a local lead entity. I mean, there has to be a local lead entity. So that's a role for locality. But there has to be that partnership with the state Medicaid agency. So, but the dollars could go to the local lead entity.
And one of the things I wanted to add is that at the TA network, we're really trying to encourage and nurture closer state relationships with localities. And so this may be an ideal opportunity to enhance those relationships. And if we can be of any assistance in doing that in your state, we'd be happy to do that.
Yeah, that's a good point.
Joe asks, will there be a requirement for local match in dollars or in kind to acquire any of the funding opportunities you mentioned?
Again, we won't know until they come out with the NOFAs, in the case of InCK and the impact bond funding. Title 40 is a federal and state match program, so in that sense, Family First does involve match from the state and or the locality, depending upon how the state is structured. But it's not the kind of in-kind the in-kind or local match that's required, for example, for the system of care grants. I think all three of them are just a different structuring than the system of care grant. I mean, Family First is not a grant. It's a change in the way $40 are used. And so, in that case, it's a major systemic change to a key financing stream for children who are at risk for child welfare, and a financing stream that could be used for mental health and substance use services and things like peer support. So it's not a grant. Integrated care for kids is really looking at sort of creative ways of getting better cost and quality outcomes in Medicaid for Medicaid enrolled children. And, it's not really requiring a match per se. In social impact bond funding, we don't really have a lot of detail on it yet. So we'll have to see what's happening there.
Thank you, Sheila. Kristen's comment is that they have gathered community data on the needs in the county, but as Sheila noted, it may not be on the state's radar. I think this might be a good entree to work with some of your state agencies, and one of the primary roles I think that communities can play is to provide input that informs data and other that informs some of the opportunities that states pursue. So you may be in a good opportunity to approach the state agencies relevant to these, Medicaid, children's behavioral health, child welfare, with your information that might inform and encourage some opportunities to look into these.
In the case of InCK, for example, and I don't know if they're on it's a long list, so I don't know if they're on this call, perhaps. But Project Connect, which is a system of care grantee in downstate Illinois, a rural community in multi-county, and the grantee, the system of care grantee there is the public health department, which also includes the behavioral health authority for those counties. And they've been implementing lots of creative things in not just through system of care, but other vehicles as well, And they very much would like to be a local lead entity, so that the public health department down there, which is the system of care grantee, and have approached the state Medicaid agency in Illinois to have that conversation. And that's what's happening in states is these local lead entities, in this case, the Egyptian Health Department, which is a system of care grantee, is going to the state Medicaid agency and saying, look, we have all of these pieces that we can put in place to achieve these outcomes and reduce costs, and let us be the lead entity. And what's happening is that they're also competing with other healthcare delivery systems, provider practices, like healthcare provider practices that are going to state Medicaid and saying, we've got a great idea and we should partner with you. So there's going to be a certain amount of, jockeying with state Medicaid agencies, but if you have something that's really compelling for InCK, now I'm talking about, you should make that case with your state Medicaid agency, because others definitely are. And as I mentioned earlier, a number of them are more hospital-based or healthcare delivery systems focusing on children with special healthcare needs. So, I would love to see more focus on children's behavioral health populations.
Any other questions, comments, thoughts?
Yeah, and in the case of Family First, what you're doing locally that you have data around, is effective, absolutely get it to the state child welfare agency to get included into their plan, because every state child welfare agency has to develop a plan that will be approved, has to be approved by HHS. I suspect that they'll be, I'm hoping, maybe this is wishful thinking, but I don't think so. I think they'll be kind of flexible and won't be too prescriptive, and, will probably go along with what the state wants to include in their plan for services and support. So getting to the state agency is really critical. And then we'll see on social impact bond funding what they come out with.
Anything else? It looks like Denise. Right. Yes, as Denise mentioned, please reach out with other questions that might come up afterwards. As she said, we'll send you a link and a registration link for our next learning community, which, as I mentioned before, it will be on social marketing and strategic communication and Children's Mental Health Awareness Day, December 12th, same time. If there are no other questions.
Beth, I wanted to just say one other thing,
Sure.
which is the InCK model and the social impact bond opportunity. They're, not doing anything around them is sort of missed opportunity, right? But with Family First, not doing anything in conjunction with child welfare and Medicaid could actually create more fragmentation, because you could end up with even more separate behavioral health delivery systems if child welfare is going off and funding its own stuff, because now it can in terms of mental health and substance use, and not taking a systemic approach and looking at how can we maximize all of our dollars and get a true full continuum in place. Because what's put in place for children at risk for child welfare involvement, it's going to be the same services and supports that are needed for all children who have or are at high risk for behavioral health challenges. So that one's really important to take a systemic approach to. The other two is I think they're fascinating and could really, be interesting opportunities, but they'd be more like missed opportunities, which is also, sad. Okay.
Great. Anything else, Sheila? Other last thoughts?
No, that was my last thought for the day.
Okay. All right. Before you log off, please hang in with us just a couple of more minutes to use the link that will pop up as soon as we're finished to complete the very, very brief evaluation. I'd like to thank Sheila for her outstanding work on this learning community and the information she shared. I think she has left you with a lot of homework to do. to see how you can apply these strategies in your own states and communities. And thank you also to Tiara Brown from the TA Network for handling all the technical aspects of the session and doing it so well as always. So thanks to all of you for joining us today. And again, thank you, Sheila.
Thank you, Beth. Thanks, everyone. Bye.